Welcome, everyone. Wonderful to have you with us. Thank you for joining for another edition of the Mystic Health webinar. And we have a very special guest today. My name is Dr. Houman Farzin. I'm the founder of Mystic Health. And in addition to that, assistant professor at McGill University and attending physician at the Jewish General Hospital in Montreal. Mystic Health is my practice operating in Los Angeles, and it's also part of a greater vision of expanding our understanding of psychospiritual sort of well-being at all stages of life. And we've been having these webinars and trying to bring figures that are important and have definitely shaped the work that is done. I mean, this is work standing on shoulders of giants. And I'm very honored and humbled to have Dr. Paul Grof with us today. I've had the pleasure of knowing him for a few years and having the opportunity to check in every once in a while to learn from the wisdom, to strengthen the compass, and to learn from all these experiences. So I'll read Dr. Grof's bio. Paul Grof is a Canadian research psychiatrist and clinician. He was a professor at several Canadian and European universities until he retired from the University of Toronto in 2022. In addition to his therapeutic and research work, Dr. Grof worked at the National Institute of Mental Health USA and as an expert at the WHO Geneva, where he chaired the Committee on Psychotropic Substances. He has been involved in transpersonal activities for over 6 decades, of course, along with his older brother, Stan. He utilized holotropic breath work and psychedelic support psychotherapy with clients suffering from severe mood disorders, mediators, and psychiatric residents. He has received several international awards for his research and authored and co-authored 575 publications and 3 books. So yeah, huge opportunity for us to learn. And with that, I'll pass it on to you, Paul, just to say a few words about yourself, and we can get the conversation started.
Well, and I'm just delighted to be here with you. I have huge appreciation, huge respect for what you have done. I, of course, hear mostly about your clinical practice from some of the patients that happen to connect with us, and I know how delighted and pleased they are with what you provide for them in a kind of very comprehensive, holistic practice, but including, of course, psychedelic involved psychotherapy, and of course you do a number of other things like this, of course, both in Canada and in the United States. So it's an honor. It's a pleasure.
Thank you so much, Paul. Yeah, it's
well,
been,
thank you for the kind introduction.
of course, no, it's well deserved, and I'm going to reveal that you're 90 years old and the way you are, and it's an inspiration, and the fact that you still show up and volunteer your time, including for patients of yours that you haven't been following for so long, and you're still there for them, and it's incredible. It's authentic work that is a privilege to witness.
Well, some of the people working in psychedelic supported psychotherapy seem to live longer, and I've developed a theory that actually for your biological age, it only counts how much time you spend in ordinary states of consciousness. At the times you spend in ordinary, it just doesn't count.
Interesting. That's a very interesting idea. So the states that are non-ordinary, in a sense, your body's not aging in the same way, I guess, is what you're saying.
I hope you accepted it as a joke.
I don't know. In today's longevity circles,
Yeah.
that's
No,
very serious.
it is interesting. It is interesting. There has to
Yeah,
be some explanation.
for sure. My understanding was that they did publish something on that there is that history. And I don't know if you follow much of the longevity sort of content these days, but there's one particular person who's been very open about his sort of this will to try to never die.
Mhm.
And he lives a very like specific lifestyle. And recently he's been sort of doing psychedelics legally and publicly, initially psilocybin and then DMT, and live broadcasting it and then studying all these lab tests, on his own body and showing
Mhm.
that it had been really beneficial.
That's interesting.
Yeah.
I should preface that probably, very likely, some of the things I'm going to say are outside of the usual range, particularly outside of the academic psychiatry. And the reason for that is that I had the opportunity to follow patients up to 50, 55 years, follow their children in our programs, follow their grandchildren, and you get a different perspective on a number of things in psychiatry.
Very interesting. And so these are patients you've been following in Canada?
Yeah.
So I guess with that, it'll be nice to understand sort of where your background was, like where you got your training, what that was like, and what were the stages to, let's say, get to Canada. What preceded that?
All the political background. Well, I grew up in Prague, in it's now Czech Republic, used to be Czechoslovakia, and was started. I got into school very early, given the Prague context, because we went to school to introduce Stan, and the director stopped my mother and said, "Oh, you have to enroll this guy, 5-year-old guy as well, because otherwise the Nazis will close the school." So it just happened. I got into medical school by 16. I got out of it at 22, and the both I and Stan had very different ideas initially about your life. And I was very fascinated by interplanetary travel. And this today, it doesn't sound like particularly interesting, but at that time, nothing like that existed. And I was really pulled into it until we read Freud in adolescence. And that kind of changed the direction. And you realized that you have to go to medicine to be able to apply that. So that's how we got into it. And of course, in the 50s, the LSD came to different European countries. And it's hard to believe these days, it was in pharmacopoeia. If you gave a patient a prescription on LSD, he could go to pharmacy and pick it up and bring it back of a session. But the truth is, initially, we did not know what it was for. I mean, Stan had we had to wait until we completed medical studies. Up to that point, you were not allowed to participate in any research. So Stan had his first session in 1956, and he asked me to be his sitter, and it was just an amazing experience. His life, how he ended up in the States and so on, it's just mystery of synchronicities. And what happened with this first LSD session, the guy who received the LSD from Sandoz, from Switzerland, was very interested in EEG. That was one of the big things at that time. And so everybody who had a session on LSD had to have also the EEG measured, but not just EEG, but with stroboscopic light. And if you've ever experienced it, that really, I think, in combination with fairly small dose of Stan, I think at about 150 micrograms, it just blew him out into the universe. And it's been with him since. It motivated him since the discovery how different things look from the higher frequencies. Initially, the first assumption was that some of these psychedelics would be good to test, let's say, the effect of antipsychotics, that you would quickly find how it works. Now that was given up very quickly. But then there was a number of studies with volunteers. And what happened was that some of the volunteers, they were of course interviewed initially, but they had LSD session and then came back and were saying, well, I just didn't tell you that because I was working and I no problems with family. So I didn't talk about these phobias and anxiety and obsessions that I had, different things, different volunteers, and it cleared up. So suddenly we realized that there is a big potential possibility. And Stan was fortunate because he came to the New Research Institute in 1961, when it opened up, and he could really choose. He wanted to do psychotherapy, but decided to use LSD for all his patients, all his studies. And as I say, you have to realize that the drug was available in pharmacopoeia in pharmacies. So that was no problem. And so, he essentially, I need to say, for about 4 years, we only saw him at home on weekends. He just would come to exchange his underwear and then would go back to the hospital. He would run 2 LSD sessions, one in the morning, one in the afternoon. And that was his life. And so that's how things started. And that's how he realized that psychedelics are not the usual drugs. They are a different. Hopefully we get into it. But so we realized the importance of set and setting and the team, the therapist and the team that stays with it. And that's how it continued. And well, how we got into United States, that's a mystery. Again, one of these synchronicities, Stan was put in jail in 1949 by the communists, accused of some anti-communist activities, which was essentially, they found some leaflet in our apartment that was suggesting that the Czechs should ask American embassy to deal with the communist turnover, that Americans really freed the western part of Czech Republic, and therefore they should be able to say about the future. And so this was a paper, suggesting that. But through a bunch of synchronicities, which are unbelievable, he managed to get into medical school. That would be a separate story. And but he was followed. He was followed by the secret police. And when we got into research institute, we were told that we can never travel outside of the Czech border. But the secret police was kind of following him. What happened? He was out of 15 people who were at the court because of this. He was the only one who was let go on condition. He some reason, right from the beginning, when they started interviewing him, he just told them that he thought this was some sexual material, and that's why he did hide it at home, and just continued with that. I never opened it. I brought it because I thought it was some, students sharing some sexual material oriented. But of course, secret police never believed it. At 1949, there was communists still were not at their peak. They still wanted to pretend that there is some legality. So they let him go. But they followed him every year, and they kept coming to him. And I think it would have been probably 64. And I have to give you a preface. At that time, the Life magazine, which was, of course, at that time very big impact kind of paper, had an article that if you put 2 kilograms of LSD into New York water supply, you could take over the city without any military resistance. So they came, and they usually tied up, put something covering his eyes, and took him some specific apartment when they were investigating him. And this time they told him, we want you to go to the United States. And of course he was shocked, because we knew that we were not allowed to travel. But he says, yeah, well, how could I do that? We'll get you a passport. We'll, it's gonna be done. But the condition is, when you come back, you have to tell us what the American army is preparing with LSD. That happened once. Of course, he came back after 2 weeks, and he said, what could I find? But I have an offer from Johns Hopkins for a fellowship for a year. So they said, okay, but the same condition, nobody from the family will leave the country, cross the border, and you come back, and then you have all the information. And if not, I think you will see. Now, of course, he didn't come back, but this was 1968. And if you don't know the history of Central Europe at that time, how every week the situation was different, it's difficult to understand what happened. Walter Pankey tells you something, I presume, the name.
Yeah, of course.
Yeah. Walter came to Prague in 1967 in October, November. And he rang the bell on the apartment and said, I opened it, and he said he wanted to talk to me. So I said, okay, but not here, because I knew that the apartment was most likely bugged. So we went up into the fields, and he told me that Stan is not coming back, and that he wants me to try to get out. Because I just came back from military service, where I was serving on the border, and there was like 30 kilometers of barbed wire, and of course. So I said, well, I would try if it was possible, but, thank him, because clearly he's thinking about me. Just all these faced calls. So I told him, I'm going to try that. He said, if you can get out of the country, he will get you by airplane to the United States. At that time, you could fly from Luxembourg for $300 to New York via Iceland. So that's how it happened. Then things started changing, and Stan had the official permission to the February 21st, 1968. So on the February 20th, I found out that people at the Ministry of External Affairs were completely confused. Are these changes happening because of Moscow or not? And if it's not, there are going to be problems with us if we follow the official Moscow doctrine. So they started giving permissions. They started So on February 20th, and the day before Stan's approval was expanded. So I managed to get to Berlin, and from there to Luxembourg, and talk to Luxembourg Airlines, or Icelandic Airlines actually, to the United States. And eventually, this will take it too far. Eventually, I decided to go to Canada, and it was a major, well, one of the problems was I was about 32, 33, and I was told that if I get a green card, I can be easily, there's a shortage of physicians in Vietnam that they can draft me. That was one of the reasons. But so it was fortunate I came to Canada, because when I worked in the United States in 1977, 78, I realized that what I was able to do in Canada would not have been possible, because the psychiatrists did refer patients to me, but they wanted them all back. Whereas in Canada, with the socialized medicine, this was not a problem. Any patients that would come to me for a consultation, and if I tell them, well, you are not well for this particular reason, you have to change it. He went to his psychiatrist, and any of the psychiatrists was very happy to send any patient to me, because there was a number of patients waiting for them. So I was able to follow patients up to 55 years. And that was very important, because, God, the mood disorders look quite different when you have that option and go and set up a program that also follows children and grandchildren, those patients. I think I told you enough.
Thank you. No, very interesting. So,
and I came to McMaster, which was a new university, so I could set up things completely as I wanted for a mood disorder program.
Okay, interesting. I just want to quickly go back to sort of what you mentioned. So you mentioned that I guess you and Stan then were not that different in terms of when you finished medical school and then you did a psychiatry.
3 years different.
3 years, yeah. And then so LSD came, and when it came, there was this notion of experiential learning, in a sense, it seems.
Essentially, because the initial assessment was that it causes type of Bonhoeffer kind of psychosis. So Stan, actually, that's interesting, because Stanberg is a pharmacologist. He published the paper in 1959 about the effect on serotonin receptors at that time, before he got into more systematic treatment of patients with LSD.
Interesting. The thing that I'm wondering is, at that point, LSD arrived, and it was a Sandoz, I guess, medication.
Yeah.
Was there any framework, like what framework was being used? Was it fully independent, or like Stan and you knew about other work being done other places, and was there some sort of foundational approach to use it, or was it completely just experimental?
It was just completely experimental. I think the instruction from Sandoz was find out what it could be good for. But it was not only Czech Republic or Czechoslovakia at that time. Samples also came to Hungary and Switzerland and Holland and England. Yeah. So we knew what was happening in those places, most through correspondence.
And at one point, did it sort of link a little bit to, let's say, what was happening in the US after the psilocybin, sort of the Life magazine article on the magic mushrooms, and then sort of, I guess, eventually Albert is the one who identified psilocybin and psilocin. And at what point did it all sort of connect to each other? Was there a point in which there was some cross sort of communication between the various sites doing this work?
Yes, there were close communication, but mainly by writing at that time. Of course, once then was in the States, that was different. And it was, I didn't say, because that's important. He came, Joel Elkis, who was the chair at Johns Hopkins, invited him initially for the fellowship and then, of course, to stay. And at that time in Maryland, there was interesting situation. There was a lot of concern about alcoholism and drug abuse, and there were initial observations that the psychedelics could help. So through political connections, I think Dr. Kurland managed to get enough money to create this Maryland Psychedelic Research Institute that was completely dedicated to study psychedelics. I think there was pharmacology, it was 4 floors, I think. Pharmacology on the top, I think animal experiments on the third. Second, I think, was some clinical explorers. First was auditorium and different experimental ways to get into non-ordinary states without psychedelics. And he arrived into that situation. So until the problems came with LSD particular, but psychedelics overall, 1972, he was able to work in the United States fairly freely.
Okay. And in terms of your own use of psychedelics, so once you moved to Canada, did you continue using psychedelics when you set up these mood disorder clinics? Or did you go shift to conventional psychiatry in a sense?
Oh, how could I? How could I have?
So it wasn't an option at that point.
Well, no, it would have been
It was
illegal.
already banned.
Sorry, it was banned.
It was already banned.
It was banned. So that was out of use. What I did use is approach to non-ordinary states in other ways, holotropic breath work, hypnosis, but could not use psychedelics on. And I was working at the university hospital. That there was no way to do that. Not until I was in, we had a private research institute that we created, small one, in Ottawa, and started using ketamine initially, because that was, of course, now it was not allowed, but it was not forbidden. So one could get away with it, particularly as there were some problems, but I was seen as a psychopharmacologist, at that time at international awards. So the hospital decided not to go after me when they found out that I'm using holotropic breath work. And, there are qualitatively the same way that you can get without psychedelics to qualitatively the same levels of consciousness. It's just much easier with psychedelics and faster. So no, until we were able to do ketamine in Ottawa. No, I used psychedelics myself, of course. That was not a problem, but that's a different issue.
Right.
Going to Amazon and going to Brazil and different places where you had easy access to different psychedelics.
Great. Yeah, there's a few things I want to follow up. I think now that you brought up the experiences to, let's say, the Amazon, I wanted to ask about that indigenous perspective and, like sort of one of the reasons I was asking about, the background of use when it first came out. I'm trying to understand if there is an indigenous link between let's say, psychedelic assisted therapy in this framework and that indigenous use that's been practiced? Is there a link? And is that link sort of the two practices get to the same place independently, or was there an influence, let's say, from Maria Sabina and other indigenous practices sort of influencing the Western model of psychedelic assisted therapy?
Well, it certainly influenced the development in the United States. That's very clear through the Harvard work and Harvard experiment and Leary and so on. But we really became only aware of that connection once we came to North America. And then it was obvious that these were two, separate developments that essentially came up with very similar strategy.
So it did sort of independently get to the same place in a sense,
yeah,
with some overlap. Yeah.
Yeah.
That's very interesting. And
well, there was
question.
much more overlap in the United States in the 50s, but that we did not know about and didn't have access to.
Right. And that was the other question is, talking about the psychedelic state of consciousness. So I was at ICPR, which is a wonderful conference in the Netherlands, just a few
you
weeks
mentioned
ago.
it to me. Sounds
Exactly. Really fantastic event. And they had a closing panel where they just choose a few people randomly last minute. And there was this idea on, okay, what is psychedelic? Should the conference even be called the International Conference on Psychedelic Research, or should it just be consciousness research? And what I was arguing is that psychedelic states of consciousness are particular, and there's some sort of unifying factor that, there are theories and working ideas, but I'm wondering how you see that, like these states of consciousness. Is there something that unifies them? And what is the link with the psychedelic compounds, let's say, accelerating and catalyzing those states?
I fully agree with you. I think the point is the solutions, the understanding. We are still at the beginning of investigating this area. We are really going to have a breakthrough when we get better understanding of the nature of human consciousness. So I think it's too early to change the name. It may come in the future, but not now. No, I think we should stay with the psychedelic term.
So I guess along those lines, talking about.
I'm worried if you ask me about consciousness, you're going to be talking for an hour at least.
Yes, for sure. No, I wanted to actually speak about ketamine because you mentioned ketamine.
Yes.
And ketamine, obviously different sort of mechanisms and a lot of downstream overlapping sort of effects with the classical psychedelics. So I want to see how you see ketamine, both from the biomedical and the psychedelic perspectives. And if you can comment on your experience with it.
Well, I'm afraid I differ from what's usually assumed. People generally assume that there are very qualitatively different experiences on different psychedelics, and that's true as long as you stay with low doses. But my experience, and at that point, I think when you stay at a lower dose, the pharmacology has much more difference. You're gonna people will tell you at a low dose that with LSD they had these kaleidoscopic visions. On ketamine, they will talk about the depersonalization that took place, and so on. And if you're gonna have ayahuasca in Brazilian jungle, then of course you're gonna have all the entities and spirits coming from the nature and so on. But my experience has been that when you get into high doses, you probably would not be able to tell what the person took if you did not know that. if you get into mystical states, if you get into the eternal factor, if you get to the real point, high frequency point, where the time doesn't factor, because brain creates this feeling of continuity, and there is no feelings for space. My experience has been that if people go into higher doses, it's fascinating experience. But if you did not know what they took, you would have difficulty telling from that experience. Unfortunately, let me say something important. We don't have data to decide on this issue yet. I hope that Rick Dublin is gonna succeed in creating these centers where you could come and you have one team, one particular setup that you stay, and you can have different psychedelic experiences and compare it qualitatively, quantitatively. Then we, I think, would have better answer for this, because when you have a very intense experience on ayahuasca, you're gonna be convinced for years and years that this is what ayahuasca does, and this is what other people are supposed to experience. But that has not been my experience with higher doses of psychedelics.
Okay, so what I'm hearing is you're saying ketamine is a psychedelic, essentially.
Well, it brings you to non-ordinary states very quickly. Yes.
Because some are a bit stuck on, how do you define psychedelic? Does it have to be like a serotonergic or not? That kind of thing.
I have trouble with that approach. I have a big trouble. Yes, the pharmacology, the particular substance starts the process. But then what continues is other factors. There is neurobiological factors, I think, that can probably explain things better. There is psychological, transpersonal factors. The psychedelic, particular pharmacology, is a trigger, but the rest, I mean, it's very clear that if you want to have some understanding of what the person experiences, you really need to know about their set, what they were expecting, what they were thinking about, what they knew. You need to know about the setting. Was it in a positive way? Was it setting that would have, created some negative direction? The team, the perception of the therapist, there is clearly almost that kind of a touch of a telepathic connection, I think, with the therapist that determines what person experience. The pharmacology is limited, important, but just a limited part. I mean, I could go over a set of statements. Number one, you can get the non-ordinary states of consciousness without any drugs. Meditation, holotropic breathwork, hypnosis, and so on. Different psychedelics have, different pharmacology. Like one is ketamine, for example. The serotonergic oriented stuff is different, and yet you get very similar states of consciousness. And I could go on and on with the reasons. But, for example, ketamine, you have number of glutamatergic substances that have the same pharmacology, but do not cause any psychedelic states. So it's unfortunate that people get stuck on this idea that it's all pharmacology.
Yeah. Thank you. That's very helpful. And yeah, we have one of the participants asking as well. You mentioned, breath work, holotropic breath work as another tool to achieve these states. And when did that importance come to your awareness? How was that developed? Like, what were the roots of, holotropic breath work, basically?
Well, there I really have to quote Stan. I think he was at SLN after he left the Maryland Psychiatric Institute, Research Institute, that was eventually closed. He was invited to SLN, and so he was talking about all these interesting experiences that his patients have on LSD and how it really gets understanding of the maps of consciousness beyond Freud and beyond Jung. And of course, people started saying, well, this is very interesting, but how can we experience it? How about some LSD? Of course, that was out of the question. And so they got this idea partly from some patient suggestions, partly from Christine as his wife, kind of spiritual work. And so they set up a group, and it was obvious that breathing and music have impact on emotion. So they developed it. It happened like this, like many things, just sheer coincidence. And from that it started. Stan came, I became involved, I think around 1978. Anyway, he came to Canada, actually, near Toronto. I, of course, took advantage to spend some time with him, so I drove there. It was near Toronto. And I arrived late and walked into the hall where the holotropic breathwork was taking place. And I was freaked out because I thought my brother is in big trouble. There's 16 people who have epileptic seizures. And so, but quickly changed my mind. And then for about 12 years, we had an opportunity to run the holotropic breathwork sessions, first of all, with meditators, then with volunteers, and eventually for 12 years with patients from the psychiatric hospital, patients with mood disorders. And I have a couple presentations on YouTube where they describe the situation and describe the individual patients, how amazing it was, particularly when the psychic energy is strangulated somewhere before your first few weeks of life. If it's strangulated somewhere back in when you were growing up in your mom, or when it's completely transpersonal, when people heal some frequent depressions by getting back to some state that is described like a past life experience, and it clears up years and years of depression. So it was very fascinating observation. It takes more work in a way than psychedelic, but it's an option. It's also we are now using holotropic breath work for inducing psychedelics into the universities, because obviously you cannot go to dean or rector and tell them, well, everybody who comes for this course is going to have psychedelic session. But if you say, they need to understand what's happening in those situations, so they're going to be breathing, they're going to be listening to beautiful music. Okay, that's okay. And then once they know non-ordinary states of consciousness, then it's much easier for them to to continue exploring that situation.
For sure. Yeah, we also used holotropic breath work for the experiential component of the psilocybin training with Therasil that we do.
Yeah, it's not bad actually to introduce people to psychedelics, maybe through holotropic session, particularly if they have some fear or discomfort from the drug. And you induce them that way and then say, well, you will just feel it strongly on the psychedelic substance.
For sure. You mentioned something interesting, which is something that I would love your wisdom on. So this whole notion of past life experiences. And I got into this conversation once with someone from Mexico where they host these events, and they're very convinced that these experiences are actually past life experiences, and it occupies a lot of bandwidth. And my personal approach is that for me, scientifically, it makes sense, especially if there's maybe like a tapping into ancestral type experiences, for example, which makes sense that they would be passed down. But what is your take on that? I mean, I guess from a transpersonal perspective, can it be a past life experience, or how do you sort of put it together?
You mean verifiable?
I mean, not necessarily verifiable, but I mean, what is your take on it really? Like, how do you?
You are taking me into consciousness, that that's a dangerous area. Well, I can tell you, I really focused now. The past 30 years have really been good for investigating consciousness. But the problem is that we are often asking the wrong questions. And, well, you're going to have to listen to this, I'm afraid. The problem is one has to ask the right question and one has to have the right understanding of the situation. And when I looked at it, I eventually came to understanding, but let me say one thing. The heliocentric and geocentric system, the belief was for a couple thousand years that we are center of the universe, the sun is revolving. The guys who eventually came up with the heliocentric thought that sun must be the third planet that's going around. And then, of course, and you had these 365 different rotations of each planet, and everything changed when the realization was that the planetary system is really revolving around the sun. And I'm afraid there's some problem with consciousness. We are just asking the wrong question, not because we are looking at it, how separate we are. But if you do some enough holotropic work or psychedelic work, you realize that we are deeply connected. If you go deeper into some psychedelic experiences, you will experience the connection. You experience group consciousness, you experience all the other things. And we are asking the wrong questions. If we want to understand psychedelic, if we want to understand past lives, you have to start with the central source of consciousness. And then it gradually falls apart and separates. And so you are really connected with different spheres of consciousness. We are experiencing our separate, but we are separate and connected. And from that angle, you have access to a number of lives. And the connection, if you experience it as your past life, then it probably also addresses something that's happening to you at that particular point and somehow connects with that particular past of consciousness. But we will only understand it when we change the symptom, when we realize that you have to start from the center, not where we experience ourselves as separate, which we are, but are not at the same time.
No, I love that. Thank you. That's actually the definition of mystic health, is sort of being at a place where we remember that the ego is a construct, but that ultimately there is the mystical extreme of us as one.
Yeah.
And so if you don't have the egocentric lens, then yeah, it's a much better way to look at it. I like that a lot.
And it's very helpful to somebody has past life experience. It's very helpful to focus on that because it usually somehow connects with the present. It can help you understand the present situation because somehow it activated that particular connection.
Amazing. Wow. The same person is actually asking, have you used holotropic breath work with psychedelic compounds simultaneously? Is there no? Yeah.
I had enough challenge with holotropic breath work and the you know the depth that we were able to reach with individual patients. It would be interesting. I'm sure people do it now. You have to ask the people who do that. But you know, I'm unfortunately screwed up as a researcher. I like investigate things simply because I like to get some answers.
Yeah, that makes sense. I know that it certainly is used,
Yeah,
and it's something that accelerates the process.
yeah,
The other thing I wanted to come back to, and you mentioned Walter Pankey, and the name of this project is Mystic Health, and
yeah.
sort of inspired actually by Rick Doblin, who's an advisor, and sort of building the capacity to be able to offer these experiences safely, whether using substances or not. But talking about the mystical state and even some of the criticism on the mystical experience questionnaire and how it may be biased in a certain maybe Christian lens, but I just wanted to see what your thought is on the mystical state, and what is the best way to assess it, and even anything about Walter and that background would be super interesting.
Well, we started in the past 5 years of my practice. We started exploring the transpersonal aspects of patients and measuring some mystical experiences, but we were not able to complete that. It partly the problem was we had a large number of patients who were severely ill in the past, but were doing very well and had no symptoms. And when I would come to them and say, well, this is nice, but wouldn't you be interested to find more about the psychological background? Let's explore it. Let's measure, some of the experiences that you may have, including some mystical experiences. Too often, the answer of our patients was, I am at work. I am, working well with the family. I had 20 years of hell. I don't want to touch it. So we did not finish. I don't have any data on that.
But what about the mystical state itself? I'm asking, like, this unique state of consciousness, again, the mystical experience. How do you view it? What is your thought on it? Is there something sacred about it?
Oh,
What is
absolutely, absolutely. I mean, when you get to the other part of the universe where there is no, you're blessed, you're in touch with the light source, there is no feeling of time. You experience that part of universe. Really, it influences. Usually, when people have this kind of experiences, it changes their life if they can bring that experience into their life and realize that they can have the experience to the spiritual, to the mystical, that it's living with them all the time. They may be only denying the connectedness. So those are my feelings.
Yeah, thank you. And
But
another question.
I know the scales, we use them in some patients, but we're not able to evaluate it because we are getting stuck in that research.
Okay. My other question, and this is the definition of mystic health that I'm trying to develop, is that, being sort of too mystical isn't always a good thing either, especially if you're trying to function as an individual. The ego serves a purpose. And one of the things that we're seeing a lot of is people having too many experiences, a lot of them actually maybe doing ayahuasca without proper integration, and coming back really with a psychosis type picture.
Yeah.
How do you see that extreme? And so is there a difference between spiritual emergency and psychosis? And how do you communicate this to someone who's a little bit too far out? How do you sort of bring them back rationally, let's say, without using pharmacotherapy, which actually a lot of people resist in that state?
Yeah, and that's usually the wrong way to go. But the question in these situations, when that happens, when somebody comes from Brazil and is psychotic, the question is, what kind of preparations did they have? What kind of guidance they had? What kind of integration they had? I think that's the major issue. And the way I see my life and the way I share it with the groups I now work with is we really live at two different dimensions. One is the material, one is the spiritual. It's the same area if you look in terms of the oscillations and frequencies that are involved. But for our understanding, for our Newton-influenced mind, we like to see things kind of clearly defined. And so we have these two ways that we live with all the time. And it's important to be aware of that, but be always very clear at which level you are actually functioning at that particular time.
Great.
And it's a big learning. It's a big learning to be able to do that. But if you can establish fairly frequent connection with your spiritual self and with all the support that exists there by your ancestors and others, I think it really enriches your life, creates and starts taking you. If you have that connection, there is some new mechanism that starts supporting your life for the purpose that you need to go. There's a big source of synchronicities that will support your life to go in the direction that you want to have as a purpose of your life. So that's
beautiful. Yeah, I've definitely witnessed that.
Now we have to. Yeah, the important thing is, because that's very relevant. Psychosis and spiritual emergence. Usually, when you have in experience, there's often a mixture of things that come together. It's a spiritual emergency, regardless of what the person says, regardless whether there are some delusions, where some psychopathology severe. If they can return back to what we would call normal health, ordinary states of consciousness, and stay there for a period of time, then it is a spiritual emergency. And that's important, because in that situation, you can use then holotropic breath work, you can use then psychedelics, even when somebody will say, oh, I had a psychosis. If it was a spiritual emergence, then you can go to psychedelic substances, holotropic breath work, whatever. You have to do it carefully, of course. You have to investigate a little bit more the person. you have to investigate the family history also to get good understanding. But there is a way of using psychedelics or holotropic breathwork or other ways of going into non-ordinary states of consciousness if it's the right profile, if it's a spiritual emergence where person has the capacity to come back. And I have used in every client actually psychological testing at the time when they were claimed they were free of symptoms. And then you could see whether they are back to ordinary health or ordinary states of consciousness or not, whether there's something lingering, anxiety lingering, sleep problems that are lingering, and so on, where the going into psychedelics with the history of past psychosis, you will probably activate it.
And that's psychological.
That's a new, because I should explain how this happened. You know, I'm sure that MAPS had it also in their instructions that if you have history of psychosis or family psychosis, that you stay away from that. And this happened, I think, partly because of holotropic breathwork, because people were coming for holotropic breathwork for weekends. And you would not want to risk that you would take person into non-ordinary states of consciousness and they get psychotic by Sunday. What do you do? So that's why it was initially in holotropic breathwork. When we were working with psychiatric patients, we had a team that would have been able to stay with the patient for another 3 days or whatever, if it happened. We didn't run into these problems, but we were set up that way because it could happen. And so it just requires really good preparation, good assessment. It's like any problem, any challenge in health.
Thank you.
I know it might be confusing for some people, but because it's new. But right. It's gradually coming up. There's a group of us, and I was pulled into that group, that is investigating when psychedelics can or cannot be used in such situations.
Very interesting. Thank you. I want to let our viewers know that we're extending this webinar a bit because we still have content to cover. Dr. Grof has some interesting findings that we'll get to, and then I know a few questions came up in the chat, so Paul, we can make it a bit conversational. So, okay. Dr. Pepper is asking about breath work, about the CO2, balance, and the brain chemistry, and which pathways do you think are influenced by these sorts of changes in the CO2? Is it like a serotonin or NMDA type pathway? If you have any input on
that. I know that Stan has written about that extensively because there was a question whether you could induce some problems related to CO2 and tendency to activate some epileptic activity. I'm sorry, it's a long time ago. I don't remember the details. But if you send me an email, I could probably send you the material that deals with that. I would try to look it up in Stan's writing. Because that
no problem. Thank you. Yeah, I'm sure it can be looked at. One question I did have for you, if you do have an opinion on it, is microdosing, because that is also like a relatively hot topic. And nowadays we have a bunch of studies ongoing, and they seem to be showing, some positive results. So do you have any experience or thoughts on microdosing?
No, I don't. As I said, I try to keep things simple. I've reviewed the literature until recently, and my understanding was up to that point that it's certainly very helpful for activating creativity, activating your mind to new ideas, to opening you up to intuition. But at that time, the therapeutic effect was still, not demonstrated. And I'm glad that some people are looking at it more systematically and see, because there is a potential, there's reason, but it's going to take some careful methodology to clarify that.
Nice, thank you. I want to let everyone know that we're recording this session and it will be on YouTube. So just that you're aware. So Rebecca was asking if you feel like your work with affective disorders has led you to unique conclusions about psychedelics that others might not have arrived at. And, with that, I think it's a good opportunity for you to also delve into what you've noticed in terms of the cyclical nature of the psyche. But any response there?
Yeah, yes, of course. I'm going to try to make it short. We were very interested. When I started and came to psychiatry in 1959, I was, of course, immediately struck how people keep coming back with depressions and manic depressive illness and problems. And was wondering how to stop it and started exploring that. But I realized that to do something about it, you actually need to know how these conditions run without treatment. And so I was fortunate to connect with Professor Engst in Zurich, and they had the same interest. And so we initially collected, at that time, it was possible to find large number of patients because there were no effective maintenance treatments. So we collected initially 1,400, now it's about over 2,000 patients who were either untreated completely or untreated during the initial part of the illness. And for about 20 years, I was working on those data, trying to figure out what happens, how come, and how come that nobody paid attention. Well, that was very clear. It's difficult to study untreated long-term courses. You have to have funds, you have to have stability of patients, you have the stability of team. There was very little, but we were fortunate to be able to get the last kind of untreated cohort. And I tried all kinds of things, stochastical, different mathematical problems, nothing could solve it. And then, as it often happens, there was an interesting synchronicity. There was several years after I was in Canada, in Prague Institute, in the Research Institute, there were two neurophysiologists, and they were very interested in motivation, and they did all kinds of studies, electrophysiology of brain in animals and observations in Zoom and so on. And eventually, based on the observation, the study in the animals, they found out that they are actually oscillatory processes, and there is certain pattern of them, well-defined pattern. And so the director of institute came to them and said, I have enough. We are a psychiatric institute. What are you doing? You're really not contributing. Can you use something, these findings that you have? I said, well, what? Well, look at some patients, what happens? And they said, well, we would have to collect, 10, 15 years observations. And how would we do that? And then somebody said, oh, actually, Paul Grof left his, because I did not know that I was not coming back to Prague, let his documentation of patients followed at that time and the previous course. So they took it, and right on the first patient, they applied a model and it worked perfectly. So, of course, it was a little bit more complicated. Anyway, there was the only patient that was successful at that time. But then we started working together and found out that the brain is a very complex system, one of the most complex in the universe, they say. And when you have a complex system, it can remain as functioning if it oscillates. And the different variables can keep changing the behavior. And what happens when people get ill, the oscillations, we found out that the oscillations actually exceed this ceiling. And the same thing happens with holotropic breathwork, the same thing happens with psychedelics. You get out of the ordinary range and get into a different high excitability range. And that's the basic explanation. And what happens, how the brain contributes is if you have oscillatory process that happens to be low, then you will have difficulty getting in a very positive experience. But if you are pretty much close to the ceiling, your ceiling, then it's very easy to get into non-ordinary states of consciousness. And it took me a while to realize that, and I would have to go into details, that actually when you are in non-ordinary states of consciousness, melancholia or mania are also, they meet the definitions of non-ordinary states of consciousness. It just happens spontaneously that these patients don't have, like in classical bipolar disorder, they don't have a good regulation around the ceiling. So they very easily exceed that ceiling. The genetic issue is complicated, but certainly plays a role in the classical manic depressive illness. And at that time, you can get very easily into psychedelic states, into states of non-ordinary state of consciousness. So it influences where you are in your brain oscillatory process, how easily or how difficult it's going to be to get into higher frequencies with the non-ordinary states of consciousness. That's probably the shortest explanation. It has very important clinical implications. The classical manic depressive illness responds very well to lithium salts, regardless of the severity of illness, regardless of whether it just manifests by occasional depressions. Lithium just, for some reason, has a special ability to turn the oscillatory down before it overshoots. And so if you follow the patient, these cycles, you can get even severe bipolar patients off medication, even for 1.5 years without a problem. Now, this is experimental, but we had experience over 30 years. And that's a huge advantage because it turns out that you essentially reduce or even avoid any side effects of the medication. So that's the practical implication. Needs to be completely tested. It's just research completed.
Yeah, so you're basically saying that, in our nervous system, we have these oscillatory patterns of going up and going down. There is this range of normal, and if we go either way, we sort of enter these non-ordinary states, which on the low end are things like, let's say, depression, catatonia. On the high end.
No. It's all happens, all non-ordinary states happen above the ceiling.
Okay, so they're all above the ceiling.
This is absolutely fascinating fact that I only realized in the past 5 years trying to compare Stan's and my data. It all happens, the high level of oscillations is the same for huge positive, very positive experiences and very negative experiences. And that has something to do, what I talked about, with the nature of consciousness. When you look at the brain, and that's a very interesting observation. When you look at the brain, and we were looking into the brain for 40 years, very systematically, hoping that we find some explanation. When people are depressed, severely depressed or manic, that's difficult to investigate, but the brain is really changed neurobiologically. There are changes almost on anything that you measure. But the shocking thing is the changes are qualitatively the same, in the same direction, whether you are miserable or whether you are high, whether you are in the hell of depression, hell of melancholia, or whether you are in the rosy high consciousness. And that's why I think we just need to study more the nature of consciousness, because we can explain the time when things happen, the intensity, but brain does not explain to us what we can experience. That I'm at the conclusion, and I had, of course, trouble the past 3 years to publish that, particularly in psychological journals, that yes, the brain plays a very important role in what we experience, but the experiences, the non-ordinary state of experiences, coming from somewhere else. They're not coming from the brain. And I'm assuming they're coming from the fields of consciousness. And there's a number of reasons I could give you. There's a number of observations. I don't know whether you want to hear that, some of that.
Yeah, please.
Well, first of all, if these things were influenced completely by the brain, then you could not have non-ordinary states of consciousness. Not ordinary states of consciousness, near-death experiences, where people are clinically dead for a certain number of minutes. For example, that was first observed during cardiac operations where they had to stop the heart and provide artificial breathing and so on. And during these states, and this is now 70 years of evidence for this, and number of studies show that person is actually clinically dead, not breathing, no heart rate. Electroencephalography is flat, electrocardiography is flat. And 1/5 of these people, when they come back, report things that can be verified. They report things they've seen while they were clinically dead on the table or in the hospital somewhere else, or they might have gone during those 5 minutes, their consciousness might have gone home and they know what people had for dinner. This is well documented. This is one area that there is some type of consciousness, something is continuing without the brain. And then there are, of course, a lot of the remote viewing experiments that were done by American Army for about 40 years that show very clearly, well documented, highly statistically documented, that you can develop some ability to view things at a distance. Now, the motivation was initially, and the reason why that research was well paid was for kind of military reasons and exploration of animals, what I want to say,
military personnel.
Well, of enemies.
Enemies, right?
That could be an approach to find out what their situation is, but it turned out that it is possible. So clearly, this is not a brain situation, and it must happen somewhere else. the fact that the neurobiological factors are going in the same direction, whether you experience the hell of melancholia or the divinity of the hypomanic or manic state. All these things, if you are willing to help at facts, if you are willing, and most people are not, but if you are willing, then you realize that the consciousness, the things we experience in ordinary states is not coming from the brain.
Thank you. Yeah, our previous webinar was on non-ordinary states, and my neurologist colleague was challenging breaking down those observations a little bit. I personally do agree with you, but I want to go back to the oscillations because you showed me the data. You've followed patients over decades,
yeah,
and you're seeing these oscillations, and you're in a sense able to tell periods where the chances of them essentially going into, let's say, a manic episode are so low that you can take them off the medications, and then as they creep in that direction, you introduce the lithium. That way you're sparing their kidneys to exposure over the years. So my question is, so does every individual have their own pattern of oscillation?
No, there are certainly established. We know from the electrophysiological experiments in animal brains what the usual patterns are in the brain, and they are applicable to human brain as well. That's why you are able to predict what the course is going to be. Because when people, for example, have bipolar illness, the classical bipolar illness, part of it is that the oscillations become kind of rigid. Normally, these oscillations in normal life can be influenced. You can prepare people for some situations where they need to be up and so on. But in bipolar illness, it gets fixed. And if you identify the particular type of and I think I showed you some of the types, a couple of the types. So then you can utilize it therapeutically.
Okay, so you're saying there's fixed patterns of oscillation that are repeated in nature. And is this both for healthy and non-healthy individuals? You have the same patterns that are observed?
That I cannot answer. You cannot do these studies frequently in healthy individuals. Put them into neuroendocrine tests and so on. The justification I had that we could utilize the findings for the patient's benefit. But I am now looking at some new approaches, and it's possible that some of the oscillations can be actually identified by looking at pulse and breathing. It's going to be interesting if some of these simple approaches measuring the autonomic nervous system can actually give us some ideas about what's happening in the oscillatory brain. But we have sufficient data only from patients at this point.
Okay, so these patterns are more in the context of, let's say, bipolar disorder. We're seeing this universality in the oscillatory patterns.
Well, the neurophysiologists, for example, who I worked with, Joseph Latt and Anna Yamamotova, they actually did investigate things in ordinary people, and there were some interesting things. I have some graphs from them that people, I've asked about 300 people, and I was investigating their past about falling in love. And Anna Yamamoto actually found the patterns of falling in love following certain of these neurophysiological patterns, and studied in some volunteers, but not neurophysiologically like we did. It's a beginning. It's but it's an important beginning because it should change completely the emphasis, because it appears that all the neurophysiological abnormalities that we can find are actually influencing the oscillatory processes.
Very interesting. And I
It's
think
a
it's worth,
hypothesis from 60 years of data. Yeah.
yeah. And I think it's important for you to talk about how you're doing this neuroendocrine testing and how you correlated essentially neuroendocrine testing to match it with the oscillatory state of the brain. Like, what is that link?
Well, what happened about, I think, 1980s, neuroendocrinology became the leading investigative pattern, and it was called the window into the brain. So we did studies with our patients, and at the end, we found out that when all the neuroendocrine activities in the brain, growth hormone, prolactin, and all that, and it actually changes also when the cortisol suppression test changes. Except measuring the other things was like $2,500 a pop, and cortisol was $40 a pop. So we started following the cortisol reaction, the dexamethasone suppression test, and that clearly showed the oscillatory patterns. When the oscillatory text becomes positive, that means that brain is dysregulated and the oscillatory processes are abnormal.
Amazing.
There may be some other, I'm looking now at some other easier ways that we could identify the underlying patterns. But I don't think this is something I'm going to finish.
I see. Well, I'm sure this work is so important. And I think with that, it's a good time to talk about, your vision for the future of psychiatry and mental health. And where do you see the value? What excites you about the future?
Okay. First of all, maybe future of psychedelics. I feel it's very good. I think, we were waiting for this renaissance for about 35, 40 years. And it's just wonderful that it has happened. And I think it will stay here. And there's a number of reasons to believe. First of all, what's going to support that movement is there is number now of conditions, particularly psychiatric conditions, that we cannot help healing without psychedelics. So I think that's gonna. It's not just PTSD and treatment-resistant depression. Now it's a number of other conditions. The second thing is of course that I think the public is for it. My understanding in some studies in Canadian population indicates that about 70% of population supports, freeing psychedelics. And finally, there is money in it. I don't know, last time I looked, it was about 25 new pharmacological companies looking at psychedelics. And there is big money in it, but that's okay if it's used properly. So for these reasons, I think psychedelics are going to be with us. There are going to be bumps on the way, of course, because when you have a very severely active process, there are risks. And if it's not used properly, people will misuse it and fight. But eventually, it will happen. Of course, the solution happens, I think, for psychedelics when something happens in the leading politicians' family. I mean, in Canada, we got the marijuana liberated because one of the prime minister's son was busted. And that led to the process that things eventually changed. I mean, and you know the Ibogaine story now in the United States. I understand it was the Kennedy's sons that had such benefit from Ibogaine is her drug addictions that there was this presidential report. So things are going to be moving forward. As far as psychiatry goes, there are two things. One thing that we need to change. I should start by saying I'm unhappy with the situation in mood disorders, particularly bipolar disorders. They are the statistics, for example, Robert Post, statistics from the United States. He was showing that about 1/3 of the patients who come for help get really some significant benefit. And that only happens when you give them 3 or 4 or 5 different medications. That is not my experience. If you properly identify, based on a clinical profile, what the problem is, you can, in some patients, some types of patients, like the classical manic depressive, you can get at least 90% of patients well stabilized. So I think we need, first of all, in psychiatry, the problem is identifying what the problem is. The DSM-5 has roots with 1900, out of 19th century. This idea that you can classify psychiatric disorders based on symptoms of sets of symptoms. At that time, around 1900, of course, it made sense to classify people according to the symptoms because, well, first of all, it was important. 19th century, you could not have all the sciences were looking for classification. Nature, of course, animals, plants, and so on. And so psychiatry as well. But at that time, if you had neurosis and depression or other problems, you went to neurologists. I mean, Freud was a neurologist. There were no psychiatrists. They were, if you come to the hospital, psychiatric hospital, they were called hospitalists. And so if you would only get to that hospital if the village could not handle you anymore. If you were too aggressive or too neglectful of yourself, that you would come there. And so they classified these severely ill patients into categories. And of course, that was not satisfactory. So changes gradually happened. And by 1970s, late 60s, people were troubled by the fact that psychiatrists cannot agree on diagnoses. And I had an interesting story illustrating that. That was, at that time, it became possible to videotape the patients or those one-way screen and so on. And so the British psychiatrists, people were worried about this difficulty. So British psychiatrists took one patient that they considered a typical prototype bipolar disorder, manic depressive, and sent that video to the United States. And when George Winokur was one of the senior psychiatrists, a friend of mine told me that they had a meeting, 80 psychiatrists showed the video. 79 diagnosed the patient as schizophrenic. And George was the only one who had, of course, international connections and had a different view on that. So then they were looking for some other solutions. So eventually Robert Spitzer came with the idea to create categories according to the groups of symptoms. The problem is that psychiatrists still have huge disagreement even when they use the DSM system. And the diagnosis actually, yes, you can agree what patients complain about, but it doesn't help you as to what to treat, what and how to treat, and doesn't tell you anything about prognosis. So this needs to be changed. And I think in our experience from the programs we had, the solution, I think, is the first step would be at least to diagnose according to the clinical profile, not just the symptoms. That you include that, but you look at the development, how the person developed. You review carefully family history, not just what the patient says, but bring one or two relatives to really get a good, clear family history. You look at the clinical course, you look at comorbidity and so on. That would help. From that direction, you can then choose treatments that will be effective. So that's the first thing that has to happen. And the other one, of course, the treatment has to change. The effort has to start at the beginning, spending enough patients to identify. Like bipolar disorder is a label. There are very different, distinctly different types if you look at the profile, clinical profile, and each of them requires a different treatment and different for acute situations and for long-term prevention. So that has to be changed. This kind of 10, 15 minutes interviews on the phone or on Zoom at the best, and then you get prescription. This has to change. This has to change. So we need a different diagnostic approach, and we need to go back to evaluating patients carefully at the beginning, because that will save the patient a lot of suffering. That will save us a lot of time that we have to experience dealing with emergencies later.
Do you see the science advancing in a way where that neurologic piece comes back, and maybe these oscillatory patterns and looking at other signs that are more objective, sort of that feeding into the diagnostic process and treatment guidance?
Yes, but I think that's a long shot. We've been looking for these biological markers for 60 years. That's how most of my academic effort went, to studying the neurobiology of patients. And then we put everything into the data from our cohorts, put into multifactorial analysis, and it turned out that the most important thing was coming from the clinical pattern, from the clinical information. Yes, there are some differentiating things. Neuroendocrinologically, you could, but who would do that? Bring a patient into the hospital and put a canal in and measure neuroendocrine thing? That's not practical. So some other things that separate patients, blood groups, but it's just very small contribution. The clinical observations separated most, provided the only differentiating information for the patients. So yes, we're going to look for neurobiology and some markers. Well, we have been. It has been very successful.
Okay. And, we don't want to get into it too much as we're nearing the end, but I'm curious, this sort of idea of archetypal astrology and that sort of input, how do you see an actual future where that kind of input can be relevant?
Yes, I think so, but it has to be archetypal astrology. Not the classical astrology.
What's the difference?
Well, the archetypal astrology is probabilistic. You look at what kind of possibilities are likely to happen. There are going to be different explorations from the archetypal point of view. I think Rick Tarnas is a real expert, and his daughter as well. I of course was looking for anything that will help me to treat patients, and I included because we had this data from untreated courses, so I gave it to a Jungian trained person looking in astrology, the classical astrology, and that was very interesting because I gave her 9 initial episodes from 20 patients and asked her, can you help me? Is there any astrological explanation for this pattern? And she came back about 6 weeks later and she said, this is wonderful. I understand it completely. Look at this patient. This episode was because of this. This was because of this. This was because of this. And I said, well, I have, for each patient, I have the 10th episode. Could you tell me when it's going to happen? And she was completely off in all of them. It has to be the archetypal approach like Rick Tarnas uses or his daughter, where you look at the possibilities, archetypal possibilities that exist and interpret it. And I think the experience, and I think also maybe the intuitive ability of the person who then uses it will benefit. There are more explanations. I think there are some people now using the archetypal astrology during psychedelic processes. So we may have some better explanations. And I'm certainly very, very impressed with Rick Darnas's findings and approach.
Very interesting. And is there a role?
He has actually some indications from archetypal astrology which sessions are going to be more effective and which take you in a more desirable direction.
I see. And is there a link between this and the sort of personality tests, like the Myers-Briggs tests and such, in terms of us each having certain personality types? Is there a link there, do you think?
I don't know. I don't think. I don't know of anybody who looked at that. My problem is, of course, I've been using these tests for 60 years, but there are a lot of things that change in over time, and that is a bit of a problem. You often, what I mean is often patients came with a particular personality, and when they were treated properly, suddenly those features disappeared and they had normal findings. So in using those things for emotional problems, we need to learn much more about that.
Interesting. Thank you. And I want to close with this question, which is not a small one, but if you could comment on it, because we're facing the situation of medicalization of psychedelics and clearly after MAP's failure Lykos's failure to take that through the FDA process as assisted therapy. There's now this effort to strip the therapy, frame it as psychological support. And what's your stance on that? Are you worried? What do you advise?
Well, I'm worried that things are happening so slowly, but I'm not worried about the outcome. Eventually, the truth will come out. And I think what's effective is the combination of psychedelic that helps you to get into non-ordinary states of consciousness, and some strangulated energies that otherwise could not be approached. You can release them. And so I think the process will continue. I think Rick-Doblin will eventually get approval. One thing, I was working with World Health Organization about methodology of clinical trials, and I'm laughing at the idea of doing double-blind studies of psychedelics. This is stupid. This is stupid. If you can recognize the double-blind, of course, I fully support it. I did a number of double-blind studies. If you deal with anxiety, if you deal with depressive feelings, it's very difficult, and we've tested a number of times. It's very difficult for psychiatrists to tell you whether the patient has received the medication or not. But if you can tell that immediately, then it doesn't make sense. In 1970-71, there were series of studies using lithium, initially in open studies, and then in double-blind studies, okay? And then in 1980, Scow and Basto put it together, and there was no difference. There was the same observations, because if the psychiatrist cannot tell whether the patient relapsed or cannot relapse, did not relapse, then you can forget about psychiatry. And if you cannot tell whether somebody has taken 150 micrograms of LSD or not from behavior, then you can forget about your ability of being psychiatrist. We have to develop different appropriate methodology. We have to have some way of measuring the set. We have to find some way of measuring the non-pharmacological factors that have such influence on the experience. Double-blind studies are inappropriate. It's a wrong use of otherwise useful methodology. So this has to change. But the truth will come out. There are effective treatments, and eventually people will not be able to hold the truth in the old approach to it.
So is assisted psychotherapy, as more of a classical view, is that necessary, or can we have a situation where you're giving the psychedelic and you have someone that's trained in holding space, but not necessarily with a psychotherapeutic approach? Is that psychotherapeutic approach key to the treatment?
There is no black and white answer, because, occasionally some people just take the drug and get well. It does happen without any support, without anything, because you just get into non-ordinary states of consciousness and things free out by themselves. So my belief is it's primarily psychotherapy that psychedelic supports, and but we cannot. There's not a black and white answer to it for that reason. Some people will get. It's not frequent. There's a number of people who did it. I have actually interview with somebody this weekend who got psychedelic on a party and had a very bad trip and is still not out of it 20 years later. So, clearly if it's used. But that could happen, I think, if you don't have therapy included, if you don't do the preparation, if you don't lead the person to what they need in the session, if you don't integrate it afterwards. Also, integration is critical. I mean, there have been studies that stand it in the American Psychedelic Research Institute with alcoholics, and they had 3 sessions, high-dose LSD psychotherapy, and follow-up. A year later, people who integrated properly, who took the insights that they learned into their life, they stopped. There was no alcoholism. People who did not do that, they went back to alcohol very quickly, even after 3 psychedelic sessions. So, no, I think the psychotherapy is essential. It's just, the psychedelic is a huge benefit, huge tool that gets us where it's very difficult to get without that.
Yeah. Thank you so much. I know everyone here really appreciated the conversation. Everyone kept saying fascinating and that we need to bring you back. So I'll get a promise, hopefully, to get you back here maybe in a few months if you had the time.
Okay.
Yeah. Thank
well,
you.
I'm really honored. I'm really honored to be with you, and honored that, and thank you that you invited me to share. I'm sure I see some things that colleagues and other ones will not want to hear, but that's the way that's what I learned over 65 plus years in Prague.
Wow. Incredible. And I know you have an event in a few days celebrating Stan's birthday, 95th birthday. It's an
Yes, I
online
was thinking
event.
whether I could dedicate this session to him, this interview. Yeah, he's going to be 95.
Of course.
And
Amazing.
really the nature, the description of the approach was really very much came from him, at least the Western approach.
Yeah. Amazing. Well, thank you so much, Paul. Everyone is sending their love and appreciates your honesty and contributions. And
My love to all of you. Well, I cannot see you, but I see all the interesting names there. That counts. Pleasure to be with you.
Thank you, Paul.
All
Have a
the best.
great day, everyone. Thank you. Be well.